Your Excellency Dr. Zainab Bagudu, I am beyond honored to host you on my second episode in the Global Health Dialogue series. You're a prominent Nigerian pediatrician and also a very well-known global advocate on women's cancers or women's health, particularly focusing on women's cancers. On a personal note, you are also a friend and a colleague. I got to know you during your tenure twice on the Union for International Cancer Control Board when I happened to be the president-elect, and later on when I was president between 2018 to 2020. So I was a witness to your valuable contribution to global cancer control. Your influence and leadership also extends globally in other platforms. You are on the advisory group for the Global Initiative against HPV and cervical cancer, and you are also on the technical group for the WHO Global Breast Cancer Initiative. So you are multifaceted. You are a mother, a great pediatrician. You are a cancer control warrior, both locally in Nigeria and also globally. And also you're a history maker. You have been just elected to become the president of the Union for International Cancer Control. This is a huge milestone, simply because you are the first African to preside over the Union for International Cancer Control, this global organization. So it is a big deal. Also, you have also earned another coveted and cherished title, which is you also have become a first-time grandma. And I have joined you in this wonderful journey. You preceded me a month before, and it has been so wonderful. I mean, my granddaughter came in November, yours in October, and it's been really wonderful to be sharing photos and milestones about our two granddaughters. So happy to host you on this platform, to host you today. And I hope during this conversation, you and I, through this dialogue, can actually detail and show our audience and bring about the issues from your global perspective as current president-elect of UICC, as well as your on-the-ground experience, throughout your work in Nigeria. My first question is, you are a pediatrician. How come your lifetime work and what you became known for actually became women's cancers? Can you please give us a bit of an experience of how that came about?
Well, first of all, thank you so much for inviting me onto your podcast, Princess Dina, and for that amazing intro. I really appreciate a lot that you have said. What you haven't said is that you have played a very significant role in my journey in cancer advocacy by being an inspiration, by pushing me, by supporting me, by celebrating me when the good is going, and even staying with me when it's not so good. So I thank you very much. And once again, thank you for this initiative. I hope that cancer control will be much better off for it. Now, my journey, a pediatrician in cancer. Many people think I'm an oncologist, but actually I am not. I am a pediatrician, like I have said. And I would say it came about as a result of destiny and fate. I was just a pediatrician in Nigeria after my specialization in the UK. I went home, came back home to Nigeria, and I was seeing children in my pediatric clinic. Now, in our community, most of the time, children are brought to the clinic, the hospital, by mothers. And in the course of this interaction, the mothers found me relatable, being a woman, being from their parts of the country with the same type of religious and cultural background. And they would start to show me things that were personal to them, lift up their veils and show me their breasts. There's a lump here. I'm having funny discharge. So through this, I realized that there was really poor awareness. And this was in the capital city, in Abuja, which is the capital of Nigeria, and probably one of the most urban areas. So I realized the level of awareness was low. And we started to have small gatherings to start with, uh, morning breakfast, coffee, evening tea time, gathering women together and just talking to them about common illnesses, particularly to do with their breast health. And that is how my journey began. This gradually evolved into something that I couldn't handle as a side program or initiative with my clinic. So we set up the Medicaid Cancer Foundation, and the rest is history. So that's a brief account of my journey into cancer control.
What an amazing story. And thank you for not ignoring these women with their issues, that you actually took it upon yourself to actually do something about it. So, really, this is noteworthy. So tell me more about your Medicaid Foundation. What is it that it does? The type of work that you do, and perhaps pinpoint the most sort of important activities that you focus on and you feel gives more impact.
Well, for us in Nigeria, low middle income country, the greatest burden that I have found in my advocacy is that many people do not have the right education and awareness. And that is the pillar of our work. We started, as I explained, with education, awareness, having events that are geared to sensitize not just women, but their families, the men, and community gatekeepers on cancer, the causes, prevention, and how to navigate it. So that is the first pillar of what we do at the foundation. The second thing is that a lot of screening facilities, the health system, as we can imagine, is a bit weak. And so screening is not easily or routinely available to women or men for that matter. And so we started working in the screening and prevention area. Next, of course, when you find things, the women ask you, what do I do? And you navigate them to a treatment center. Oh, I can't afford it. So we fundraise, and we also have access programs that help people to access chemotherapy much easier, in that we go into partnerships with the pharmaceutical industry, and chemo drugs are made available at a non-governmental price to those who need it. And has been a very successful program. It's called the PACE program, whereby people can access chemotherapy drugs at a much cheaper rate than what obtains even in the government-controlled hospitals. Next, of course, you try to do your own bits, but without government and without focusing on the health system holistically, it becomes more difficult. So the need for high-level advocacy to government, to the lawmakers and policymakers, and to other community gatekeepers like the traditional and religious rulers, culture and beliefs play a very significant role in how men and women respond to a disease like cancer. There are different types of ingrained presumptions that make them address it in a way that is not ideal for the outcome that we desire. So we work with all these people to try to change the narrative and improve health-seeking behavior generally, and create better laws and a more conducive environment to battle cancer.
That's really amazing. I mean, definitely the role of advocacy is so important. And I'm sure you do that. I know you did that for cervical cancer. You work on cervical cancer, which I will come to in a bit. But I'm sure you do that the same for breast cancer. And I understand you also work on prostate cancer, also on training, or like you said, on healthcare workers and this sort of thing. Let us talk about your work on cervical cancer. Cervical cancer, we know it's the second highest burden of cancer in Nigeria for women. That's the bad, but the good news, it is one of, the only cancer that can be prevented, early detected, and treated. Um, Tell us more about your championing and your advocacy with the government to help actually making the rollout of the first ever vaccine rollout for girls between 4 and 19 in October of 2023. How did that happen? How did you convince the government?
Well, it was a long journey and with multiple stakeholders. I cannot take the credit for it alone. Partnership is one of the key things that has made it, that made that goal successful. Cervical cancer is the second commonest cancer in women in Nigeria, and it is one of the cancers that we can eliminate. WHO in 2018 started a global initiative for called the Cervical Cancer Elimination Initiative that is based on three pillars. That is vaccination, screening, and early treatment. If we do these three things with the right political will, the right resources are available, the tools are available, we can actually eliminate cervical cancer in the world. And there are some countries that are doing very well in this. So I took it upon myself to work with the stakeholders, the vaccine provider, named mostly Gavi, the Vaccine Alliance, our own internal government structures, to try to convince them that Nigeria was ready and we could have the vaccine. Finally, in 2023, like you said, we had the rollout, which was launched by the First Lady, Senator Remi Tinubu, and it was very successful. The first rollout saw 7 million girls being vaccinated. The second rollout added on another 6 million. We got to 12 million. And now, with the routinization by the primary healthcare agency, Nigeria now has at least 16 million girls that have been vaccinated with the HPV vaccine. The work doesn't end there. Routinization is an issue. Overcoming the barriers and presumptions and preconceptions, negativity, misinformation about the vaccine was a Herculean task. Many people thought that the vaccine, because of the target age group, young girls, and we were not talking about boys, we were just talking about the girls, there's this feeling that it's being used to make them have no children or fewer children. So we had to battle that through the media, by physical outreaches, sensitization in the communities, working with the women, families, schools, teachers, education authorities to overcome those barriers. But because the numbers are so large, that is why we have been able to overcome them. And we still have a significant proportion of the population coming forward to get the vaccine. So it's been successful, and I'm very, very grateful to all the stakeholders that participated and supported the outreach. The current coordinating Minister of Health, Professor Pate, led that initiative very, very strongly. And with both steps, we have been able to reach where we are today. Screening is still a bit shaky, and we're working on how we can ensure that the primary healthcare centers provide screening to women that are eligible.
But that's amazing, and I read somewhere that this rollout was the largest first rollout in the whole of Africa, and because, like you said, the numbers are big.
It's a large country, yes.
And but funding, the governments, of course, still relies heavily on international donors like Gavi, like the Vaccine Alliance, UNICEF, etc. Is the
Absolutely.
funding still sustainable? Because if you have, you like you said, you have two phases. If you don't have the funding and the vaccination schedule is disrupted, then the work is, the results will not be the
Oh,
same, given
yes.
certain vaccinations come in many doses. How is it really doing? I know we can't go from 0 to 100. It's still
Yeah.
a fantastic progress, but you know, is the government fixing the issues as they come along?
Well, I'd like to say yes, but in reality, government has a lot of conflicting priorities, and the amounts that are being put towards cancer control is not adequate. We do have donor support. We hope that that will not be withdrawn, particularly with the current situation from our usual donors like USAID and Gavi, as you mentioned, the Global Fund. We were at the point of actually seeing vaccine. The HPV and cervical cancer patients included in with HIV twins, so that the PEPFAR program was going to provide a lot of support for elimination of cervical cancer. Now, with the shaky global situation when it comes to global health and funding, that will be a problem. And that is why advocates, the organizations that are involved in cancer, the Nigerian Cancer Society, have taken it upon themselves to regularly and strongly advocate for more funding to fund our cancer control programs. We do have a national cancer control plan, and that is due to end in 2027. It's ongoing, but it's not adequately funded. We have a cervical cancer elimination task force, which I co-chair, but that even the task force is not adequately funded for sensitization activities, for screening, and even for early treatment. We received support in pockets across the state from an organization, CHAI, and this was focused on the screening aspect of cervical, for screening for HPV virus. It went well, but after, as you said, it dried up, and to continue has been a problem for government. With COVID, we were able to create a lot of facilities that can do the HPV high performance tests, the molecular testing that is the gold standard for HPV testing. And those facilities exist across the country. And what we need to do, or what we're doing, is advocating that those facilities be utilized for HPV screening as well, because the platforms are there. But of course, the consumables are expensive, the human resources, the manpower. These are all issues that
Yes.
that need to be addressed. And so the short answer is 50-50.
Well, first of all, I'd like to highlight, the fact that people think that you get the vaccines and the solution is there. There is so much more, and you said the importance of sensitizing the community and beating the stigma. And it was the first time I hear that people. I used to think people worry that cervical cancer promotes promiscuity. That was one issue, but now you also say that they suspect that you might want to stop them have children. These are huge beliefs and myths to destroy, and like you said, it needs a lot of work to do that, because having the vaccine is one thing, delivering it, and I know that there are some issues with cold chain storage. That's another issue. And then, Nigeria is huge to reach rural areas. And then when you reach there, you have to convince the people to work with the religious leaders. It's a big thing. It really is a big issue. But still, 50-50, that's okay as long as. But that really brings me again to when you mentioned the cancer control plan. And I want to tell our listeners that just, the scale of the population in Nigeria. You are 234 million people. I mean, in Jordan, we are 12 million and we think it's a lot. So it does seem daunting. It does. The scale is big. It is daunting, but that is why people should start having really doable, actionable, proper cancer control plans. Because, it is overwhelming, because I have to remind our listeners that, Nigeria is playing catch up. And not only Nigeria, many countries in low middle income countries are playing catch up. Why? Because the global health infrastructure, even prior to 2011, they only decided somehow, and that came, of course, along with the funding and the support, etc. They decided that low middle income countries are only busy with communicable diseases, fighting communicable diseases like malaria, HIV, and tuberculosis, and that high income countries are the ones who are burdened with non-communicable diseases. And as a result, Africa in particular was delayed in laying the infrastructure for cancer. And we know very well the infrastructure for cancer is a complex and expensive one. You can't just have a normally trained nurse. You need an oncology nurse. You need the machinery, the radiotherapy machines, the infrastructure, etc. So having a national cancer control plan helps year on year to slowly start ticking the box and laying the right foundation, so it's not ad hoc. And this is why it is so important to have national cancer control plans, and more importantly, to have a line item, budget line item. Does Nigeria have a budget line item for national cancer control plan?
Yes, we do, for various aspects of the plan. Like I mentioned, cervical cancer screening, even for breast cancer screening. Having a line item is good. Having the plan, first of all, is good. Advocating for the right funding in the budgets, as the Ministry of Health does, is also good. The issue comes from funding it. Not all the lines are funded every year, and some of the appropriated funding is inadequate. Most of it, actually, you've mentioned so many things: the human resources, the infrastructure, the equipment that is required for cancer. They're all very complex and expensive and time consuming. It takes so many years to train an oncologist, to train the medical physicists. And then we buy these machines, they're not maintained regularly. You have to wait for weeks on end for a specialist to come. Even the biomedical engineers that are meant to do all the maintenance and so on are not easily available. So these are all issues that the funding does not directly address. Right now, we have an ongoing program whereby there are going to be 6 new radiotherapy comprehensive cancer control centers with radiotherapies. 3 of them they've resumed the construction and all, but it's still not addressing the issue of human resource and all the other things. Power, regular supply of power is an issue. Even water, having the right water to the hospital. So all these are government responsibilities and need to be addressed more through better funding, and realizing that without them, we cannot really make the progress that we need to make in cancer.
But I have to bring something. It came to me this morning. You are married to His Excellency, to your husband. He's the Minister of Budget and Economic Planning. He has your ear. If I were you, if my husband was the Minister of Budget and Economic Planning, I would make his life hell until he puts extra zeros on the right-hand side.
Well, I do my best. I come with all the advocates. we gather, we have him listen to us. He's very supportive of the journey, I must say, and he does give us the right advice on how we can get more funding and so on. But yes, he does need to do better, and I hope he listens to this. He and
Listen
all
to
his
me, Your
colleagues,
Excellency.
we need him to do much
We
better.
should,
Under him, we saw more funding allocated.
important. If non-communicable diseases, including cancer, are not going to go away. And the need is only going to increase and increase unless you make a very doable national cancer control plan. It doesn't, like we said, we don't have to go from 0 to 100, but to
Mhm.
actually have the political will to actually tick certain boxes. And I speak here from experience because when we try to deliver comprehensive cancer care in Jordan, in the beginning, imagine we had the building, we had the latest equipment, we even had in Jordan a very sophisticated landscape of healthcare personnel. We're very very well known in Jordan for that. Yes, we didn't have enough oncologists at the time, but we certainly had all the elements to start well. But we couldn't deliver comprehensive cancer care because we didn't fix our governance and we didn't plan and organize ourselves well. And it was only when we did that's when we succeeded in delivering quality cancer care. And that is why, Nigeria or other low middle income countries, yes, it is overwhelming. But for example, had you had a doable cancer control plan that fits your landscape, your resources, the starting landscape, and the resources available in 2007, maybe you would have had more than the 80 medical oncologists that you have now servicing 234 million people. Maybe you would have had double that amount. So all I'm saying is that it's never too late. Look at your plans, look if they are logical and doable, and actually start implementing those plans. Again, funding, before I forget, there are also other ways to get funding. For example, with the cervical vaccine programs, invest in your own vaccine production to stop relying on international funders, especially now with the climate that we have now. For example, you can start to lay the foundation. It might not happen now or next year, but you lay the foundation for that. And the funding can also come from taxing the industries that harm us. The food industry, you have issue exactly the triple wins. You harm the industries that actually make us have the burden of NCDs. And there are many countries who have utilized that. They're taxing sugar, they're taxing salt, soda drinks, smoking, etc. So that's, it is doable if you have a plan, but more importantly, you have the political will. So this comes to another question for you. What is the direction of Nigeria in terms of delivering cancer treatment? Is it the comprehensive cancer center model whereby you put different centers of excellence in every region, because obviously the geography is big, or are you still going for the cancer center in general hospital department? Because that is linked, and I think once I hear your answer, linked also with stopping the brain drain of oncologists, and I will share also with you our experience in Jordan. So what is the direction for Nigeria?
So the health system in Nigeria has the primary health care, which is the most basic in the communities, in the rural areas, and the first ports of call. Those are that offer the routine treatments like for malaria, injuries, accidents, and so on. And then the secondary are the general hospitals, which are really government controlled. These first two. The third one is the tertiary hospitals, which are usually the teaching hospitals. It is in the teaching hospitals that cancer care is delivered. Like I mentioned earlier, we are still trying to institutionalize screening in the primary healthcare system. There is no routine call for women or men to come for their breast or prostate screening at a certain age
or the facilities do not exist. They can treat malaria, they can treat children with pneumonia, they deliver all the childhood vaccines, and of late they've added on the HPV vaccine. But to walk into a primary healthcare center to get screening is not routine. And then the secondary are where the diagnosis takes place. They do not have adequate diagnostic equipment. Not all the general hospitals, I would say maybe 10%, have working mammograms and ultrasound scans. And then when you come to the tertiary hospitals where you're supposed to have all the modalities of treatment, chemotherapy, surgery, radiotherapy, we're not even going to go into the new innovative gene therapies and so on. But it's not adequate at any given time. I think right now we have 7 functional radiotherapy machines spread across the country, and the distance that patients have to travel is a lot. It's expensive, and it can sometimes be even dangerous for them to travel those distances. So provision of more of these centers is urgently required, which is why the government is now working on these 3 new cancer centers. There's also a lot of work going on to produce vaccines locally, like you mentioned. And I thought I would just chip that in there, that yes, that is on the table, and there has been funding for that. It's just to get all the elements that are required correctly. So comprehensive centers is the way that we go, but they are inadequate. And most of all, the manpower to run them is grossly inadequate, coupled with the already low numbers of specialists that are required in cancer treatment. Is the brain drain that you mentioned. We have seen a lot of professional flight to greener pastures from Nigeria and other low-income countries, with active recruitment, especially during and after COVID, by the countries that can afford them.
But I want to share with you the experience at the in Jordan. When I was director at the King Hussein Cancer Foundation, and of course the team, we obviously started to fix our one comprehensive cancer center, and we were an NGO and still are. So this, once we center and it became accredited internationally, it became the sort of the model for delivering quality cancer. Again, health needs quality. Quality is not some luxury item. Quality is about safety and actually achieving the desired result, which is to save lives. And the fact that once we stood on our feet, first of all, having that center, it became the focal point because we put all our energies in that, became the prototype of how to deliver cancer care, comprehensive cancer care with excellence. It became that prototype for governance, bylaws, and that, when we did that, and of course in partnership with St. Jude, we didn't reinvent the wheel. We literally copied and pasted the governance and structure with St. Jude, which, so kindly opened up their books. Good partnerships do make a difference, but you do have to have someone at the other end that actually knows how to utilize it. Yeah. So that became the prototype. And now our center is actually advising the ministry, on cancer. It is helping to train radiologists, physicists, clinical oncologists. It is actually managing one of the general hospitals of the government hospitals. It is running an amazing accredited fellowship program, churning out, like you said, more and more clinical oncologists for Jordan. And even Jordan, we suffer from a lot of people going to greener pastures, as you said, to the Gulf states, Saudi, and so on, because they get paid more. But because we have created the engine locally to create quality, better trained clinical oncologists by the center, it's okay. Some will go, but you still have many that will be able to service the need for Jordan. So I totally recommend the model of especially in low middle income countries. I know WHO always says, oh, we have to strengthen the existing health system. Because I was like you on the ground, facing the challenge with the team, not by myself, of having to deliver quality cancer care, even for one center in a small country. So I can imagine the challenges for a country as big as yours with 20-fold the challenges. It was hard. And, the low salary that are given by the government hospitals, how are you going to bring the brain drain? When my child was being treated in the US, I saw Jordanians, Palestinians, Iraqis, Lebanese, all in the US. Many would have loved to come back to make an impact in their own countries, but they couldn't because of the salaries. But when we had our comprehensive cancer center and we made a decision to incentivize these doctors to come back, yes, we did not match their salaries in the US or Europe, but we gave a good salary that will allow them to put their children in good schools, live in good neighborhoods, and so on. And that was a tactical decisions to bring them, and then they became the leaders that trained others. So there are things to be done. We can't keep saying shortage of this and shortage of that. Something has to give. Something has to be done. Otherwise, the problem is not going to go away. And I know Morocco did the same, and I hope Nigeria will do the same. And then what about childhood cancer? I know me as a mother of a cancer survivor, and then you as a pediatrician, I know your universal health coverage schemes that started to cover limited cancer coverage, but only for adult cancer patients and not for children. How is that? Tell me. I mean, it must be heartbreaking. Only the rich people.
Particularly because childhood cancer is one of the cancers that can be cured with the right medication, the right detection at the right time, and giving them the medication. The commonest ones, lymphomas, leukemias, have a 90% cure rate and above. But for us, it's in the region of 20% because of poor detection, late detection, and inadequate access to the chemotherapy and other treatment modalities that are required. Yes, the Cancer Fund does cover, which is the National Fund for Cancer. It does on paper now cover childhood cancer, which is part of the efforts that advocates puts in, and the National Cancer Control Program now has it on paper. But in reality, children have not started to access the fund yet. And also the drugs that are required for treating the common Burkitt's, lymphoma, and so on are available now on the Chemotherapy Access Program, which is another government-led access program that provides treatment. So the drugs are available, but the funding is not.
Yeah, I'm sure. At least you're moving forward. So I understand it is overwhelming. I sincerely hope that childhood cancer, especially, with leukemias that have 90% chance for cures, it's so tragic to have someone child in a low middle income country actually has 10% chance of a cure. And you and I were in that field, and I can't even begin to imagine knowing that the miracle drug is there or the miracle treatment is there, but I can't get it because I'm in the wrong geographic place in this world. So I sincerely hope that universal health coverage and through other tools and partnerships, that this can become a reality to help more children. Did Nigeria apply for the WHO Global Initiative for Childhood Cancer? Because Jordan signed. We were the first to sign, and I think we're going to get around worth of 1 million drugs for free. Have you signed, let alone the collaborations and the technical support and so on? This could be...
Yes, the Global Childhood Cancer Initiative is in Nigeria. It's operating out of a few of the tertiary centers that I mentioned. For now, they are focusing on the technical aspect training, support, capacity building, fixing the systems so that they can have better protocols and pathways for treating childhood cancers. So it's just, again, the same thing with the case of oncologists and medical professionals that you were talking about that are needed for better cancer care. It's the critical mass, the number. We have to just get there. All these things are in place, but it's going to take time before we can get the critical mass that will reverse the trend, even in terms of brain drain. Yes, there are many going out. Yes, we have more private universities now that are offering medicine as a career, and other centers that are doing nursing or oncology. More and more are beginning to offer it. But that critical mass still hasn't been reached that is required to reverse it. It's a really big problem, human resource. We have to look at the pull and push factors. What are the incentives in place to bring them back home? It's beyond salary. It's about their social welfare. It's about having, a car and being able to access petrol for their car or diesel, and having the right schools for their children and the nutrition that they need, affordability. Security is another big one. Training opportunities and research. Research is really very low on the African continent. We do not have clinical trials. These are all the things that make professionals grow in their career. When they have access to and ability to fund research, they can actualize their thoughts and their ideas and really see if they work. But again, those are areas that we are now advocating for. I haven't spoken about my role as the chair of the First Ladies Against Cancer. It's a role that enables me to, we work together with other First Ladies across the states. Nigeria is divided into 36 states. So we work with the First Ladies to using their platforms to create awareness, to advocate for better support and engage partnerships. One of the partnerships with BVGH and First Ladies Against Cancer is on childhood cancer. We were able to create a lot of educational materials that is directed both at the patients, the parents, as well as the healthcare workers, particularly those in the primary healthcare centers. And not just in English, we were able to produce these materials in 6 different languages. There are about 100 languages in Nigeria, but the major ones, as well as English and Pidgin English, we produce these materials that are now being used to educate about childhood cancers, the common signs and symptoms, what to do when you have them, and so on. So these are some of the efforts that are ongoing.
My next question to you, Dr. Zainab, is about AI and digital health. You spoke about that earlier. And we all know that many countries are utilizing this technology to help with access, efficiency, and delivering quality services to the population. In my last interview with Jordan's health minister, he told me that in a couple of months down the line, he will be announcing the establishment of a virtual hospital, one that will have a virtual clinic where people in rural areas can access expert advice from the virtual clinic without having to travel. At the same time, this virtual hospital will have a reading hub for radiotherapy and radiology scans. Again, we know that it's a global problem. There's always a shortage of radiologists, radiotherapists, and so on. So again, this will help in providing quality readings for those places or hospitals who don't have the capacity. Of course, Jordan has also done electronic medical records, and it took some time, by the way. But thank God we started, 7 years ago. And now it's doing very well. Other countries are doing virtual hubs for pathology readings and so on. So there is good use for AI and digital health nowadays. What is the situation with Nigeria? Are you utilizing that in a good way?
Well, like with other forms of the latest technology that evolves, Africa including Nigeria and other countries, are playing catch up. A lot of the AI models do not contain data from Africa, from the Black people. And so AI is just based on previous intelligence. So what you put into it determines what you get. If we haven't put in data from people of Black origin, then the results are skewed. However, what we're doing now is a lot of research is ongoing. In the cancer area landscape, we have bodies engaging in research that are pulling that data for breast and prostate cancer in particular, and those are being used to feed into the models. So it is coming, and it's a way that we're hopeful, as you said, will help to overcome the human resource issue. But as always, we need to focus on the LMICs and ensure that we have representation and equal inputs into the technology. We have brilliant oncologists, brilliant scientists that are using this in a lot of ways, but we need more, and we need people to be more aware and educated in that area.
I totally agree with you. This is a very important point that you made. Dr. Zainab, you've also, I'm just picking up on some things that you've said earlier, and you yourself have looked at the broader women's health issues. Your foundation works to support the fight against breast cancer, cervical cancer, and also even ovarian cancer. So what I would like to pinpoint here to our listeners, the fact that it is so important to look at people as human beings, as one body, because what's been happening so far is that the global health infrastructure has somehow made us be divided into constituencies and coalitions, whether we are divided into organs or communicable disease versus non-communicable disease, as opposed to a patient with one body. And the problem is that this has informed the organization of the healthcare system on the ground, and more importantly, it has informed in a negative way the donor and funding of the global health community, so that it started to skew, and there was a bias between communicable and non-communicable diseases. And we all know that if there is a virus or a communicable disease starting, money will flow. But of course, the same doesn't happen for non-communicable diseases. And it is very different from how the business sector copes with this. You in your clinic, you utilize that opportunity of contact with the healthcare system by the mom to actually talk to the mom about her own health as well as her kid. Yet the health sector in general doesn't do that, and it's highly inefficient. Whereas the business sector, for example, utilizes every contact with their customer. For example, you go to the supermarket and you think you're about to buy only essential goods. By the time you reach the checkout, you have picked up this extra chocolate or magazine or chewing gum, and they really make sure to profit from you. And so I would like your thoughts on that.
Well, it's a very important concept. It's slowly catching up, not as efficient as it should be, but trying to use the opportunity is something that a lot of programs are looking at now. Obviously, because there's less funding going into women's health than any other issue. In Nigeria, huge amounts of funding, over $1 billion, $1.07 billion, in collaboration with the World Bank, was announced just 2 weeks ago. The Project Hope is looking at maternal health, and not just delivery issues, prenatal issues. It goes further into infant mortality rate. We are hopeful that it will cover basic things like screening, where the infrastructure is poor. It's basically focused on the primary healthcare system, which is usually the first point of contact for the majority of Nigerian women. So by increasing and improving that infrastructure, by strengthening the numbers of the professionals that are available, we are improving the healthcare system, strengthening it, and ensuring that more is covered at that level. So it is a very important concept, and one that, if we're going to make advances in women's health, is very, very important. I serve as a champion to the World Economic Forum Women's Health Alliance, and this is the whole idea. And what we're trying to do is to champion the fact that when you see a woman use the opportunity to deliver essential health services. Has she ever been screened? We talk about cervical screening. Every woman must have at least one high performance test in her lifetime. Does the facility offer those the services for screening and so on? So it's very important, but we need the partners and those that are providing these services, both within and outside country, across the world, to agree to that concept. You don't just throw money and say, oh, this is for HIV. Like the PEPFAR program that was recently stopped, it started primarily on HIV. But as it evolved, we are seeing that screening and treatment for cervical cancer is being coupled, particularly for those women that are living with HIV.
Absolutely right. I remember even hearing about some patients wishing that they had HIV and not cancer because the system was in place. And yes, logical thinking is to ride on the same networks. The same networks that reach the communities and rural areas. You can couple it with advising the very same people, their contact with the health system, about early detection, prevention, anti-smoking policies, whatever it is.
Health education.
The health system needs to be thinking about that. And then that leads us about the smoking burden. I'd love to know, what is the smoking burden in Nigeria? I know in Jordan it's super high and we're fighting it, somewhat successfully, but still a long way to go. How is it in Nigeria?
Well, it's the same. It's not as high as in some high-income countries, but the barriers to starting that habit are not in place. We have recently been doing a lot of advocacy for increasing the taxation for tobacco industry, as well as sugar taxation. But what happens is, despite the legislation, we do not have those funds that are coming in from the taxation. Initially, it was quite minimal, but slowly over the years, it's going up. And that is what we want to see. If we have high tax enough, people buy cigarettes and take to high income countries because it's cheaper when you compare the strength of the US dollar and so on. But with adequate taxation, that will change and reverse. Like I was saying, what happens is that the funds are not ring-fenced to the health system and health infrastructure. The ministers will battle out in the executive council and tell you that, a road is really desired in this community. And if we build a road leading up to a healthcare clinic, then we have strengthened the healthcare system. Yes, but we would like to see more direct use of those funds in the health system.
Absolutely. And I think this is what happened in the Philippines, where they targeted the taxation on tobacco to help underprivileged people get cancer treatment. So that's
why advocacy and building awareness is important, because that was championed by a member of the legislature, a senator, I believe, a female senator. And she was able to successfully bring the advocacy, pull all the people behind her, so that the lawmakers and, governments are always in somehow awe of the lawmakers. because they can remove and impeach someone. So they drove that drive, and it was ring-fenced around NCDs, not just the health system. Yes, the road improves the health system, but we need it to be directly focused on non-communicable diseases. If we say that these vices, tobacco, sugar, are directly impacting the rates of non-communicable diseases, cancer, obesity, diabetes, then we should use those funds for cancer, obesity, diabetes.
Yes, absolutely. It only requires political will, and it's a triple win. You reduce the number of cases now, whether in obesity, smoking, or diabetes, etc. And at the same time, you stop an avalanche of future cases, and you get money. I mean, it's such a win-win formula.
Absolutely.
Where is the political will? And I just want to add that it's very important at the fact that you still have a low case of tobacco addiction burden. Please keep it that way. Do not add it to become a huge problem on your list, because it's a very big one.
Tobacco rate is huge. Any tobacco rate is huge.
Yes. I mean, I know we're suffering a lot from that. So make sure, I would love for whoever is listening to make sure that, on your cancer control plan, to, follow all the FCTC recommendations and put on the plan, because you know what? These big multinational companies, they are eyeing up Africa the same way they've been eyeing up the Middle East. And so as the GDP of Africa is rising, and they obviously, their markets have
business opportunities,
Europe, etc. They want the lungs of our youth. So please make sure that you fight it in the same way as if you had a big burden, to make sure it doesn't become a big problem. Dr. Zainab, you are now the president-elect of the Union for International Cancer Control. And in 2026, you will assume the presidency. I would like your thoughts about how important representation on such international boards by the very people who face the worst burden of cancer.
Well, thank you, Princess Dina. And I'd like to use this opportunity to thank all those who felt confident enough in me to elect me to that position. The UICC is a very important global body, as you know, as a past president in the cancer landscape, in terms of global advocacy, capacity building, fellowships, and creating opportunities at the national level so that we can translate global initiatives into national action. So this, my election, and I hope the tenure, the 2 years that I will have as president, is going to be seen as really the underserved populations of the world, the low middle income countries, and women in particular are serious, are able, and with the right support, I will drive a lot of catalytic changes in cancer control on the platform of the Union for International Cancer Control. There are over 1,100 members spread over 72 countries. And so that network is vast, and we can really drive the messages. We can engage leadership of countries. We can work with the members to make sure that we reach the grassroots of countries so that cancer awareness and knowledge, as well as initiatives that are touching the lives of those patients with cancer, really, really make a difference. The theme for World Cancer Day, which is going to go on for 3 years, is United by Unique. And that is really focusing on people, to see people as the important factors when it comes to cancer. There are so many different needs, but we're all united in the fact that we want to see a change and we want to have better outcomes. So I look forward to assuming the leadership of the board, and with the support of the board and the management, implementing a lot of the wonderful plans that the UICC already has in place and ongoing.
Yeah, but what is the importance of representation?
It's important because it's, like you said, you are facing the problem. When you have experience in that field and you know the context in which to drive these national plans, then you're likely to succeed more. There's so much human social research that has shown that if we bring messages and somebody, Princess Dina, you come to my village, you don't speak the language, they don't relate to you. Unlike if we use the civil society and the other way around, if I go to Jordan and just start trying to teach them, it's going to be very difficult. So on a global scale, when we have women with high burdens, the highest cancer is breast cancer in women, and we really need to have people that understand. The reason I ended up in oncology, like I explained earlier, was representation. Women could see a similar woman and they were freer to share their problems. Or also, if we look at recent research like the Women in Power Cancer by the Lancet Commission, there's been so much evidence that was shared in that commission about the fact that women are underrepresented in oncology, in leadership positions, in research and clinical trials, and even in remuneration. So we need to have women that are going to speak up more. And if I'm from a low middle income country, then I think it's a win-win situation. We need to occupy those positions, be at the table, and drive the experiences that we have and we wish to see in the global action.
Yeah, that's absolutely true, Dr. Zainab. Representation is key because then you have the diverse perspectives about many health problems. And if that voice is not on the table, it's a missed opportunity. Dr. Zainab, what would you like to see from the global health community and the donor health community do better? What would you like to see?
Again, we're on representation and we're on inclusion and we're on clearer understanding and input of the plans that we're making. A lot of programs come with a plan. Yes, the countries, they sit to 1 hour meetings, maybe virtually or physically now. And but the plan, the goal is there. We do not take into account the local context. That is so important, and how to implement this and drive that action at local levels. So there is a need for better cooperation. There is the need for understanding what we're trying to achieve in that community and how we can achieve it. It's the amount of fund is important, but do we have the support that is going to get that there? In some cases, we actually do. We had a cervical cancer elimination program in Kebbi State, and that was under the UNITAID program. But we had to take the samples from the women to the central lab because it was only the central lab that was recognized by the funding. That was one of the conditions. But and that took time. That could cause delay. There was a time when the central lab in the capital, which is 7 hours drive, was under repairs and wasn't functioning. So that whole time, women were not getting their results. And what happens when there's a delay in results is that you lose the positive cases to follow up. And in the meantime, we had the platforms available. Thanks to COVID, we now have molecular diagnostic platforms across the country. There is no state that you don't have at least one and more molecular diagnostic platforms. And so we could have done the testing locally, is what I'm saying, but the terms of the funding didn't allow it. And I, tried to advocate, but we thought, okay, let's start it. So it creates a difficulty in sustaining the programs. If they're just used to putting it in an envelope and sending it up to the capital and not used to doing it, a lot of the facilities are just lying dormant now for the COVID testing because we don't have COVID. COVID anymore, but there are so many other tests that we could be carrying out, in particular the HPV, and it's one of the strongest pillars through which we can eliminate cervical cancer, as we all know. So there needs to be more inputs, more aggregation of available resources, and leveraging on those existing facilities so that we can have better outcomes and better use, more efficient use of funding that we're seeing. Sometimes also, I'd like to talk about incentivizing healthcare workers. Programs do not cater for incentives for healthcare workers. So we have an HIV program, or let's stick to the cervical cancer elimination program I mentioned. It is expected that part of the job of the partner, in this case the country, is to provide the health workers. The health worker is employed to run the primary health care clinic, to see pregnant women. They have a job description, and they turn around and tell you, this is not in my job description, so I'm not, obligated to do it. So it's a hurdle that we have to go through. And really, it creates extra work on an already burdened healthcare worker. Somebody has 100 women that he or she has to see, a nurse, and deliver their prenatal care and talk to them. And here I am with my new system and telling them, do their HPV tests and catch them when you can. We need to incentivize them, not necessarily financially, but in terms of, there's so many ways to do it, making their working conditions better, capacity building trainings. Yes, there are trainings, but having them really have a qualification from that. And so there are other ways in which it can be done better.
Yeah, I totally agree. And it really confirms the point that we spoke about earlier. This is about looking at the status of the processes. At the end of the day, it's the processes that need to be looked at, how people are navigating the health system. And just because they were done in a certain way 50 years ago, if there is a plan and a good look at the health system as it is now, looking at the challenges and the blockages that exist, reorganizing the process of how to deliver care.
Excellent care.
And like you said, it will create efficiency and clarity, and it will create the right environment for the health system to maximize the contact with their customers at that point, not duplicating that and requiring many more healthcare workers. Mm-hmm. And I hear from what you are saying also, you're talking about, when talking about partnerships and what we wanted from the donor community, I heard the fact that you're asking for long-term partnerships. You're talking about equal partnerships, whereby the partner who's helping with the funding and the design of the solution, so to speak, that they actually sit down with the locals and together they decide what's feasible, what's doable, and what's logical, as you said. You said the story with the samples having to travel 7 hours to the central lab. And here I would like to bring the example of the amazing partnership between the government of Rwanda and the organization Partners in Health. I mean, this is such a good partnership to talk about. That partnership started in 2005, and it was such an amazing partnership. On the one hand, the organization Partners in Health, they want, led by one of the co-founders, the late Dr. Paul Farmer, who such an amazing human being, who, along with his team, went to Rwanda in 2005 and sat down with the government, and together, and this is where I want to underline the word together, they brainstormed what the government can do, what they can do to actually speed up reform and speed up impact. That's what you want at the end of the day. Mm-hmm. And this partnership, so you're talking about 20 years of partnership. Throughout that time, they have strengthened the health system. They've established so many district hospitals, a cancer center, which I had the privilege to visit. At the same time, they've established a university to churn out the future medical leaders called the University of Global Health Equity. Together, they did that. On the one hand, the government, what's beautiful is that the government facilitated and removed all the obstacles for the entity, for the partners in health to work in, owning up the project, not just waiting passively for help to come. I mean, that's the main thing. At the same time, partners in health, the fact that they started to see impact, they were more energized and incentivized to do more. And that is why we all have heard about the revolution of healthcare in Rwanda. So it's very important to have equal, not fly-by partnerships, but long-term partnerships that work on the ground in the country to make...
I think there are many lessons to be learned. There are many lessons to be learned from the Rwandan experience, political stability, and even instability. The reason why partners in health were very keen to get the inputs of Rwanda is the instability that they had just come out of. That's the reason they were there. In 100 days, you saw 1 million people killed. And this alarmed the world. What was the entire world doing at the time that it happened? So the inputs and the desire to see change was there. Secondly, there's also the will of the new government, which, as I mentioned, has remained stable, but also the will of the people. And finally, I need to mention women. We all know that the Rwandan story, whether in health, infrastructure, across board, there is a dominance of women. The equation is more favored in terms of female representation. So women tend to be more stable and more dedicated in their jobs. Without taking anything away from the men, but Rwanda is a typical example of a success story whereby there has been equity in terms of, in so many aspects of development. And we are seeing continually the results of that. Rwanda is the first country in Africa, not even South Africa, that has more resources, more human capacity, and so many other things in their health system that is on the way to eliminating cervical cancer. They recently launched their Mission 2027, and it's hopeful that by the year 2027, they're already at figures like 90% of their immunization rates and screening, early treatment. So all this is going on at a tandem with the partners, and there's that input. So there really is a lot of lessons to be learned from the Rwandan experience.
And like you said, political will is key. And I love that you brought about the issue of a lot of the reason for the healthcare revolution in Rwanda is that they achieved equity in women in leading positions. And that's definitely a lesson for our listeners to learn from. Because it's a missed opportunity when global health is delivered. Actually, 70% of the workforce delivering global health are women, and yet very few reach leadership positions. This is such a missed opportunity, and Rwanda has proven that. Last but not least, tell me about what more would you like to see in terms of collaboration across Africa in your region? What would you like to see happen better?
I have a wish list of maybe 1,000 things, but that's not to say that it's not doable because of the number. I'd like to see more cooperation between our countries, between our leaders, between our civil society and people generally on experience sharing. We've spoken at length about Rwanda, about Jordan, and a little about Nigeria as well. So what are the good points that we can take away? And I believe that is why platforms like this are important, in sharing our experiences with each other and also looking at each other to see where we can help and take home some, not just messages, but practical solutions and practical interventions on what to do. Maybe somebody listening didn't know about the CCAN model. We've spoken about it and they can apply, and that can help them. So there are lots of things. If we're able to see more cooperation across board, then we're definitely going to see more improvements in the cancer landscape. There needs to be more awareness and more efforts put into the existing programs that we have from all sides, from the politics, from the leaders, and from the citizenry themselves. I want to hear political will become a buzzword. I want to hear citizens' will become an even greater buzzword, because the government provides certain things, but the citizens, either they don't know, they're not aware, or it is not used optimally as it should be used. We have things like demand generation. Nigeria, we've spoken about the HPV vaccine delivery, but demand generation was a huge task, or it's a huge part of it. How do we engage people and equip them with the knowledge that is required so that they know that this vaccine is there and we're going to access it? How do we change their health-seeking behavior? It's a Herculean task, and I hope that with time and with more practical inputs, higher education rates across board, male, female. We focus a lot on girl-child education, but we also have boys that need to be educated so that we can have a more, brighter future in Africa. I would like to see our rates in cancer go down, or at least stabilize, and detection, that is the low-hanging fruit. Let us have earlier detection so we can save much more lives.
Thank you so much, Dr. Zainab. Honestly, I feel with you we could go on, and we can, I'd like to unpack so many things you said in every single sentence, but I think we've already covered quite a few issues. Thank you for an engaging conversation.
Thank you for having me.
Listeners feel the same. I look forward to meeting you soon, maybe in Australia, in Melbourne in October.
Yes, at the World Cancer. No, that's too far, Princess Dina. That's in very well.
Maybe earlier.
I'm sure I will see you before.
And please kiss your wonderful granddaughter for me. And thank you again for being a fantastic guest.
Thank you for being a fantastic host.
Thank you very much.
Thank you, Princess Dina. It's been an absolute pleasure. And again, I repeat, this is a wonderful podcast, and I hope that it gets a huge amount of listeners, viewers, and a huge success. Have many more relevant guests that are going to really promote the drop of cancer. Thank you for having me.
Thank you. Thank you, Dr. Zainab.